I'm chair of the panel. So, as is normal with these things, we'll do some housekeeping safety information first. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at Queen Victoria statue. In order to comply with the Guildhall Trust fire marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting, not during the fire alarm. So today's meeting is live web streaming. So I want to draw everyone's attention to that. Everyone speaking via microphone will be on camera. So members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. So please can everyone use the microphones and remember to switch them off when they have finished. So just starting the meeting, I'd like to welcome Councillor Matthew Cordy to his first meeting to the panel. Who replaces Councillor Lee Tyndall. So we'll do introductions around the table. So I'll start from my left first.
Councillor Vivian Atchwell, Winchester City Council, and I represent Whiteley and Shedfield Ward.
Councillor Leslie Minahan, local Borough Council of Town, Gosport, and Hampshire County Council as well. Thank you.
I'm Councillor Philip Raffelli. I'm the Gosport Borough Council representative.
Councillor Charlotte Gerarda, Central Southsea Ward in Portsmouth. I'm not a member of the panel, but I'm just visiting for one item. Thanks.
Councillor Graham Heaney, Portsmouth Council for St Jude Ward.
Good afternoon, Matthew Cordy, member for Hilsey Ward.
Afternoon, Leonie, councillor for Baffins Ward. And can I just put on record that I want to say thank you to Mark and everybody for changing this time because I've been unable to attend up until now, so thank you.
Lisa Gallagher from Democratic Services.
Thank you, everyone. So members have read the reports. So presenters, please just highlight any developments that have occurred since the publication, and then we'll have questions. So I've had apologies received from Councillor Gerald Vernon-Jackson. And the next thing is, are there any declarations of interest? Has anyone got anything to declare? No? Okay. So straight on to agenda item 3, so minutes of the previous meeting. So I'm going to go through the pages, and if anyone has anything that needs correcting, please let me know, and then at the end, could I have a proposer and a seconder to agree the minutes? So on our document pack, page 3, is there anything at all? Page 4? Page 5? Page 6? Page 7? And page 8. So the minutes are agreed. Do we have a proposer for that and a seconder? You propose it and a seconder? I don't think you can second it if you weren't there. Thank you. So we've good help, but sorry I can't take that help. But we've got a proposer and a seconder, so the minutes are agreed. So thank you. So we're going on to item 4, which is baby loss awareness. Councillor Charlotte Gerarda has been invited to speak under Standing Order 55 at the invitation of the panel members, because on the scrutiny panel for health, it's normally just members of the panel that speak, but we sent around an email and we agreed that would be appropriate. If you want to, you don't have to. And also, at the end of this item, if you do want to stay, you're most welcome, but if you want to go, you can as well. So we've got agenda item 4, baby loss awareness. I think we've got Joe Waterman, Nicola Reid, and Kaylee Emmy, is it Emmy? Do you want to come forward and just sit where the microphones are? Thank you for coming today. So if you could just give a brief, we've read the report, so if you want to give a brief summary of the report, you're welcome to, and then members will ask any questions. Thank you.
Hello, good afternoon. My name is Nikki Reid. I'm the Senior Sister on Ward B4, Gynaecology and Early Pregnancy Service.
Good afternoon, I am Jo Waterman. I am the lead bereavement midwife at Portsmouth, along with Stephanie Fretter, who unfortunately can't be here today.
Good afternoon, I'm Kaylee Arney, and a third year student midwife.
Thank you. So, members, do you have any? You've read the report. Do you have any questions at all? Councillor Cordy.
Thank you, Chair. I noticed that it states in the report that we want to get maternal deaths down by 2025. The charts sort of range from 2013 to 2022. I didn't know if we had any data for 24, 25 yet.
National reporting data always comes out on a bit of a delay, so we have only just had Embrace published 2023, so we won't have that data until the end of this year or next year.
Can I just say I forgot to invite up Maggie West, who was a late addition to the notes here, so apologies for that. Do you want to just say what your role is?
I was invited sort of last minute because I actually work in the early pregnancy clinic and have been involved with bereavements at QA since the 90s.
Thank you for coming today. So, Councillor Cordy, did you have any follow-ups on that one at all?
No, Chair.
Okay. Any other questions on this issue?
Thank you, Chair. Do we offer any support to women who lose their babies before 24 weeks?
Within the early pregnancy, our guidelines are up to 12 weeks. We have the miscarriage support group, which is off-site, which research has shown is better for families. That's once a month, held at the Cosham Community Centre. We work with charities, so I think you've seen in Jo's report they provide study days and they give us items we can give the families and so on as support.
Sorry, did you say that was up to 12 weeks?
Yes, for early pregnancy. The 12 to 20 weeks officially goes into gynaecology, of which those ladies will go to the ward.
Yeah, so any lady 12 to 20 weeks gestation, miscarriage will come to Ward B4. We will care for those ladies and families and provide them support. We have strong links with the midwifery bereavement service and some of my staff also have specialist bereavement training as well, including myself. So we do have very strong links for that bereavement support. We have an awful lot of written information we can give to the families for ongoing bereavement support once they're discharged from the inpatient care episode. So they do have that information. If they don't want to access anything right at that moment, we know there can be delayed responses and reactions and emotions. So they do have that information at home available to them. And there's a lot of online resources as well, which we can provide that information for them as well.
I just think that's really good, Chair, because pre-24 weeks, a lot of women can feel that their loss almost doesn't have the value of a baby after 24. So thank you for that.
Councillor Ashwell next.
Thank you, Chair. You mentioned in your report you have 2 SANS teams, one in Chichester and one in Portsmouth. Are there any other around Hampshire, do you know? That's one question.
So Portsmouth and Chichester SANS is one team which works together to cover the area, but SANS is a national charity, so there are others in different areas all across the country. That is the one that we link closest to because that is where the majority of our women are from.
One more question. And is there any support for those parents that have lost children due to cot death?
That isn't sort of within our remit. We tend to see women who lose babies in pregnancy or in sort of the first month after. However, we have had some families who in subsequent pregnancies have come to us for advice and support, and we are more than happy to support them with that. They will also be seen in a specialist pregnancy clinic called the Rainbow Clinic, so they'll have additional scans and consultant appointments throughout their pregnancy because we know they've had a previous loss, so for a bit more reassurance for them.
On this issue, is this on this issue? So I've got next, Councillor Oliver.
You state your, well, not yours, the miscarriage, the 3 miscarriage rule. Is there any reason behind that, and who sets that? With what evidence? So it states here, the 3 miscarriage rule means that women with undiagnosed underlying health issues are forced to go through multiple, in many cases, preventable miscarriages before receiving treatment.
Sorry, in your presentation?
That was an item that was brought by the council.
Right.
So that's not mine to answer because that's beyond.
When people have had 3 miscarriages, they're
Yeah.
referred to the recurrent miscarriage clinics, and then there are further investigations. When they've had 2 miscarriages, then they give us a ring and we organise an extra scan at that point, because the latest research has come out that if we give cyclogest pessary support, it will help.
Right.
And so we've taken them on.
Okay, next I've got Councillor Raffaelli, then Councillor Harris.
Thank you, Chair. And thank you for the report. It's a really important and delicate subject for many people, and it's clear what's going on here. What it doesn't address is, I think we're all aware, certainly nationally, there's been real recruitment and retention problems in the midwifery part of the world. Is that affecting Portsmouth? And then linked to that as well, there's no national standard for bereavement midwives. Is there any move to change that? Because if you're already having to recruit from a difficult pool, if you don't have a clear standard, it might be quite hard to get the right individuals and to keep them. Thank you.
It's kind of above my level to comment on what our staffing and retention is. That would be for our senior management team. In terms of there being no national job description for a bereavement midwife, the way we did it locally was we put out the job advert and then we were interviewed, and it was dependent on what our clinical knowledge was and our experience with pregnancy loss. And certainly when I got the job, it's then developed through that role, hands-on, with the support of a bereavement midwife who has been working there much longer to continue. We also have lots of links nationally with other bereavement midwives. We have an online forum. We attend meetings to all discuss what we are doing. Although there's no job role specifically, we try to provide a cohesive service across all trusts.
Yeah, if there's any, on this,
I'll come back to the manning in a minute. But on the bereavement part, part of my question was also, although I didn't make it clear, was it is a challenging role. And one usually thinks of midwifery as wonderful, you're delivering babies and new life, it's really great stuff, but it's not always like that. You know that. And the bereavement counselling part in particular is at the real coalface. Part of having a national standard, from my perspective, would be a proper support mechanism so that people who are having to deal with this on a regular basis are then self-supported. Do you feel you're properly supported in the role you do?
Yeah, we have great support. We have a wellbeing matron at Portsmouth, so she's a good link for us, and also our senior management team. We also have psychology meetings nationally, which we can do over Teams, and they are bi-monthly, so we get support through that as well from someone external to the trust.
Thank you. I'm happy with it. But coming back on the manning, I'm not asking for policy. You're there every day. Are there enough of you there every day would be good enough for me or not?
It depends on what the acuity is on the service. Some days, yes. Other days, no.
Thanks. Any more questions on staffing at all? So next I've got Councillor Harris.
Hello, thank you. You stated near the beginning of the report that the stillbirth for black ethnic groups and for Asian groups is higher than for white groups, and although the proportion in Portsmouth is less, is there any reason for that, and any action being taken to try and address that imbalance?
So nationally, Embrace report every year, and that has come out in a number of their reports. In Portsmouth, we have got continuity of care groups, so women from ethnic minorities tend to go into these continuity groups, so they have got the same team of midwives caring for them antenatally, in labour and postnatally, and what has come out is that continuity of care does improve pregnancy outcomes. Nationally, SANS have done some work around black and ethnic minority groups, improving support available for them, so they are able to access support specific for them.
Do you have a follow-up on that one?
So would you feel that black and ethnic minority women do feel supported and aware of their additional risk, as it were, and you know, is that addressed you know, verbally with people, or is the strategy gone on in the background, as it were? Does that make sense?
I don't really do community, so I don't see women at that first contact or through the antenatal period, so I'm unsure what midwives do through that. But I would say that women are aware. We are doing a lot of work on making sure information is published in all languages, and we are making sure that women who struggle with English, they are not reliant on the apps that everybody else has, but we are directing them specifically to the website where it can be translated for them.
Any more on this issue? I've got Councillor Girardeau next.
Thank you, and thank you to the Chair for inviting me to come along. The sort of original motion that came forward came from me because I'm a councillor, but also experienced 2 miscarriages before I had a pregnancy, my rainbow baby, who's now 15 months old. And I think I have to sort of explain a bit about what happened to me to explain where I think the sort of shortcomings were, where there's gaps. And I think probably since it happened to me, it sounds like the service has developed a lot, because this was in 2022 when I had my first miscarriage. And I was at 10 weeks pregnancy, so just like really close to having my first scan, thought everything was absolutely fine. And then woke up one morning and was bleeding and completely unaware of, you know, sort of miscarriage and the symptoms and what to do. And so the first thing I obviously did was try to contact the sort of main midwife contact number, the sort of maternity unit number, and they explained that I needed a referral to the early pregnancy unit, and the route to do that would probably best come through my GP. But the age-old problem of trying to call your GP and get hold of them happened. So I was on hold for a really long time. Finally got hold of my, I was down to number 1 in the queue, and then the line cut off. So they actually had the phone off the hook at my local GP practice. So while I was alone, because my husband was away and bleeding and confused, I had to like go to my local GP in my car, get a physical form from them to get this referral and make them aware of my situation in person, because obviously they took the phones off the hook. And then was trying to just sort of like get information and find out what I should do. And I did speak to lots of different health professionals. I called up, as I say, a few different places, maternity sort of hotline being one. And I think, you know, people were trying to sort of diagnose the situation that I was in by just hearing some of my symptoms, which made me really confused, because I was trying to work out, is this a good thing that this is happening, or is this a bad thing? I was just very confused about what was, you know, taking place. And as I say, was alone, so it was just absolutely awful. Then eventually, I think the advice I was given, because I did speak to someone, I think in the end it was via, I can't remember if it was the early pregnancy unit, it probably would have been 111, I think, in the end, which was just sort of like hang tight, because we don't really know what's happening, but from what I described and the amount of bleeding that I was having, it obviously wasn't serious enough to go to hospital at that point. But for somebody who's experiencing that, and you know, who thinks that they're potentially losing their baby, you don't want to just sit out and wait at home, because you want to think, well, I've done everything I can potentially to save my baby, and I didn't know what you could do, or if you could do anything. So my sister sort of insisted that we go to A&E, and she took me straight away, and eventually obviously got this referral to the early pregnancy unit in QA. And the staff there were obviously absolutely amazing, and I can't fault anyone who was there, because the care, is incredible, and obviously everything's handled so sensitively. But from what they could see, they weren't sure if it was a miscarriage or not. So I was again sort of told to go home, but I had this sort of open access to the early pregnancy unit, which was obviously really good. But then my symptoms really worsened. The bleeding got heavier, and I felt really unwell, so I came back in, and again I was sent away. And I understand that obviously there's limited space and the hospital's under a lot of pressure, but I ended up like basically bleeding a lot at home to the point that I couldn't stand without fainting. I think I lost like 60% of my blood. It was just ridiculous, basically. So in the end, I was brought in and was offered a D&C and was kept in. But I'd obviously got to a point where, you know, I'd been left for a bit too long probably at home. I shouldn't have waited as long as I did. So by the end, I was just so unwell, on top of obviously feeling the grief for losing my baby. I did have the procedure, and then at the time, I don't remember all of these wraparound services, so I don't know if they existed then, but I basically was given a leaflet, a miscarriage association leaflet, and that was it. And then I didn't have any other contact, and there wasn't any other sort of wraparound support. No one else contacted me or anything. And I found the most healing thing was talking to other people who'd been through the experience, just sort of informally, and hearing that they did go on to have successful pregnancies, and that actually, you know, there's light at the end of the tunnel, essentially. But the grief that I felt was just, and the pain is just like nothing else. And, you know, I lost my dad and spent a week with him while he was dying in hospital, which was like awful amounts of pain. And this was so much worse because you feel so responsible for your body, and you blame yourself, and you think about everything you've done and what you could have done. And to not have that kind of broader support there was just, I was quite shocked by it. But I did a lot of research myself. Tommy's are like amazing charity, and obviously read up a lot about their PRISM trial and getting access to progesterone treatment when you do fall pregnant again. And actually on their website they say, you know, take this to your doctor and encourage them to refer you like when you fall pregnant again, so that you can get this the additional support that you need. So that's what I pushed for basically when I did. Well, I did have another miscarriage, but it was nowhere near as bad as that first one. And then when I got pregnant the third time, I went back to my doctor, and thankfully they referred me. And again, I had amazing support with extra scans and everything, and the progesterone treatment. And obviously, I don't know if that is what meant I did have a successful pregnancy or not, but I did have a successful pregnancy and now have a healthy baby girl, and I'm so grateful for that. So I wrote down like a few things where I think there are, potential gaps, or where things could be different or improved that would just make a really big difference. So I think a lack of information about miscarriage. I know obviously there's like a balance to be struck, because when someone falls pregnant, it's a happy, joyous time, and you probably don't want to be like putting lots of negative things down their throat. But actually, it is a reality, and it's obviously very common that it happens. So, actually telling people about the symptoms and what to look out for and what to do, and just so people, are more aware of it, I think would be really good. That confusion about being referred to the early pregnancy unit and having like a more clearer pathway where I'm not having to go from pillar to post, like in the, the moment of having a miscarriage, I think would be good. Yeah, this, again, I know that the NHS is really stretched and there's pressures, but this whole being encouraged to sort of wait it out at home and not knowing what's happening to you or your body is, that's, if that could be changed, I think that would be really good. The sort of aftercare, from what I've obviously read in your report and what you've described, it sounds like it is different now, but I think, that support afterwards is just, so important, because the miscarriage is only a part of the process of pain. It's, it lasts for a long time afterwards. I mentioned about it being, the sort of informal talking is definitely very healing. And I think this is just a broader sort of thing I think there is this sort of assumption that there's this inevitability about miscarriage with just the medical profession in general. And obviously it is true that a lot of women do miscarry 1 to 2 times before they have a successful pregnancy. But it's just sometimes in my interactions, like with different GPs, when I would talk to them, I'd just be like, oh, well, yeah, of course, that just happens. And I know there's lots of unanswered questions about why it happens, but just having that kind of attitude of, it's inevitable, it's just one of those things. It's so horrible when, a woman's going through it, that you don't want it to be one of those inevitable things. And then something that Councillor Oliver touched on, which was about, the current national policy, which is, you have to wait for 3 recurrent miscarriages before you then get referred for further investigation. Yeah, I mean, obviously I know that's a national policy, not something that can be done locally, but I think if that could change, and if we could have Tommy's graded level of care where you're not having to wait that long, it would just, make a really big difference to women, and hopefully prevent more miscarriages from occurring. So sorry for the long ramble, but I felt I had to explain my personal experience to give context. And thank you for everything that you do. The staff at the early pregnancy unit would, just amazing, and I'm so grateful for the care that I received there.
Thank you. Are there any more questions from councillors at all? So, Councillor Cordy.
Thank you, Chair. Thank you, Charlotte, for that. It was really heartfelt. Thank you. My wife, unfortunately, went through the same thing, and hearing your story sort of brings back some memories there for sure. We had really great care with the nurses, and I was just wondering, the report states that all the staff that come into contact with bereaved parents receive the bereavement care training. I wondered if this includes sonographers as well.
So in our training, ours is just midwifery specific. So for midwives, every year we have to have a trust update training, and we're included on that. We have offered additional training from external services which come in, which sonographers are invited to, and our gynae colleagues are invited to as well. But because we don't have funding to pay people for that time, it is on a volunteer basis who would like to come in their own time, so the uptake does tend to be quite poor for those.
Yeah. Okay, thank you. That's a shame, really, but thank you.
Any more questions from the councillors? No. Okay, so thank you very much for coming today. That was really helpful, and thank you for your report. We're going to note your report. You're welcome to stay for the rest of the meeting, but we understand if you do want to leave the meeting. So thank you for coming today. Okay, so the next agenda item is agenda item 5, which is Portsmouth Hospitals Trust. So we've got Simon Barson and Dr. John Knighton here. So in your own time, if you want to come forward and sit at the desk there. We've read your report. Thank you for your report. If you want to give us a brief summary, you're welcome to, and then the members will ask you questions. So could you introduce yourselves first? So thank you.
Yeah, so I'm Simon Barson, Chief Operating Officer at PHU.
Good afternoon, everyone. I'm John Knighton, Chief Medical Officer, and I've met some of you recently in the hospital. Thank you.
Yeah, we had a really good tour of the emergency department, so thank you for that. Okay, so did you want to say anything about the report? We have read it. You're welcome to.
Yeah, so I think, as you said, you read the report. I think since the report, obviously, this is looking at January, February, we've seen continuing performances in ED that have improved. So our FARA performance has gone up again in February compared to January, which is positive. We have again seen increase in attendances again in February compared to January, so that growth in demand at the front door, predominantly the emergency department, has not abated. We have continued to see improved ambulance handover performance, which I think we even described in January with our SCAS colleagues, with an average of 16 minutes handover against a national target of 15, so 1 minute off. But compared to the previous year, when we were at 55 minutes in the same month, it's a dramatic improvement there. We still have challenges within our organisation in terms of occupancy, so the trust is still running beyond occupancy levels, particularly in our medicine care groups, which is a challenge for us, and our non-criteria to reside, so our medically fit patient numbers remain high at around 247 in February. So challenges there in terms of flow through the organisation, which means expansion of the organisation in terms of escalation space through February. In terms of the elective programme, so we have continued the focus on 65-week waiters, and we are still on trajectory to achieve a 0 position for 65-week waiters by the end of March, with the focus then moving on to 52-week waiters, which again is a year, which is substantially longer than we should be for these patient groups, but has shown a real drop since August, around 1,000 patients from where we were to where we are now. So continuing focus there is key moving into April, May and June in this new financial year. In terms of cancer performance, that continues to perform well, so 62 performance is good. as are the other three. Pressures there are similar to the elective programme. It's a similar speciality that are having the same challenges, but obviously we'll keep focusing on there. And DMO1 position, so our diagnostic targets remain fairly static at around 55%. So again, there are a number of key specialists there that are challenged alongside the elective programme as they are on the diagnostic programme. But obviously we will continue that focus from that perspective. But I'll pause there on the update really from the report to where we are today.
Thank you. So members, do you have any questions at all? Councillor Ashwell's first.
Thanks for the report. On page 27, just at the end there, I think there's some text missing because it says 65 weeks and we're on track to clear the backlog of long waiting patients by the end of, and there's nothing.
Sorry, apologies, by the end of March.
I must admit, I picked that up and didn't see it either. Good spot. Yeah, do you want to ask another
so
question?
on your table on, just bear with me, sorry, page 8, where the GP practices, so that's page 8. I couldn't quite understand what the first column meant. And it says, I'm looking at me on health services, so it's 517 patients. I mean, how many doctors are there in the clinic seeing that many patients? I didn't quite
I
understand
think that's the another agenda item. I might be incorrect. I think that's relating to. Oh no, I'm wrong. Oh no, I'm agenda item 6.
Yeah.
Yeah, so we're
That's not this report.
we're on 5. Sorry.
I'm sorry.
Oh, that's all right.
Apologies.
Don't worry. So next I've got Councillor Heaney.
Just a point of clarification, the table on page 28, which had the March 2025 figure sneaking onto the top, it was a little unclear. That presumably is the national. The labelling of the table is a bit unclear. It says RTT incomplete over 52 Portsmouth Hospital Trust. And then the figure is, well, I'm not quite sure what the numbers at the side there. There's 4,500, 3,500. Is it 3,500? Yeah, that's right. So that presumably is the number of people waiting 65 weeks or more.
So that's the number of people waiting over 52 weeks.
52 weeks, right.
In totality.
Okay, so over 52, right. Because you talk about 65 weeks in the text, and then the table isn't entirely clear. So if maybe a little explanatory thing under the table saying that refers to 52 weeks, so we just know, because it was a little bit confusing. I had a second question, which is a different topic, which was actually on the non-criteria to reside paragraph. It talks about an average daily of 252 patients. Have you got a sort of average time for these patients who aren't needed to be in hospital? And then what's your longest one? Have you got any idea of what those are? A sort of an average and then the longest.
Yeah, so average is slightly challenging because there's 3 separate pathways for these patients. So you've got P1 pathways, P2, P3, and the number goes up the more complex the pathway is. So averages are quite tricky in terms of delays against those, and also you have a split between Portsmouth and Hampshire in terms of those delays. From that perspective, so that's a challenge for us to provide that. In terms of the other element, so I think, sorry, what was the question again?
It was about roughly sort of what's the general length of stay.
So in some terms we're talking months. So longest wait as of yesterday from a Hampshire perspective, because they do change, was 58 days from being fit. So that doesn't mean they were in the hospital for longer than 52 days, but they had a period at the start where they were unwell. So from the point that we deemed them ready to leave, it was 58 days. For Portsmouth, it was around 30. So we do see a variation between Hampshire and Portsmouth in terms of the delays in terms of both areas. Obviously, Hampshire's feeding a bigger population cohort and more hospitals than just us.
Okay, next I've got Councillor Meehan.
That was quick. When the elected hub comes on board for hips and knees, hopefully in October this year, obviously that's going to be a great help for you guys. What percentage of your hips and knees do you anticipate going there? Thank you.
So percentage-wise, I don't have the number. We'll be getting 2 days a week in the unit.
Do you have a follow-up or? Anyone else have?
I just do the maths because it's 2,500, I think, a year, isn't it? So, anyway, it all helps. Thank you.
Any more on this issue? Councillor Raffaelli?
There was 2 points, if I may. One was to pick up on the delayed discharge from care. Previously, there was a clearer separation between medically fit for discharge and the delayed charges from care, and there was a lot of specific effort going on to work with having a predetermined pathway for people, and you had actually in-house people working really hard to address this issue. That all seems to have disappeared. How are you trying to address the end-to-end care, as some of these patients have to move seamlessly from hospital care to step-down care to reassessment care into proper care at home, whether that ceases to be medical? They can't go to the whole end-to-end package. How are you working together with Portsmouth or Hampshire? And all of that's maybe going to change anyway with the government rearrangements. So you know, the further ahead you are now, the better for the future, I would speculate.
Yeah, thank you for the question. The terms have changed, but actually the work hasn't. And those processes and the focus on the different pathways of care that Simon talked about are absolutely the same as they were. If anything, they have become more embedded as part of normal practice. So we have a daily and a weekly rhythm of focusing on those patients who have the most challenging requirements for onward care. Whereas we perhaps in the past had a cyclical focus on some of those most challenging patients, or the patients with the greatest challenge. That is now an embedded weekly series of discussions, and we do have the people that you talked about who are working within the hospital every day. Those are absolutely part of our normal practice now. Well established probably for the last 4 or 5 years, I think.
A follow-up to that is you're clearly within the hospital. It's under your own control to the degree, and I trust you're working as hard as you can do that. What do you see as the biggest challenges outside the hospital environment? Because some of that could be influenced by the county council, the city council, or the county council. So where could pressure be put to help you?
Yeah, I mean, so that is it's the $64 million question, because it's absolutely the right question from my perspective as well. I think I would answer it in 2 ways. In headline, I think it is firstly to not admit people to hospital unless that is really what they need and the only thing that will improve their care or provide the support and intervention they need. And that obviously goes without saying, and yet still too often it is the default or the only available default at the time at which someone presents with an acute need. We know that there are numerous alternatives when available that can provide a better outcome and a better experience for patients rather than admission to hospital. And the work that we are doing, that ICB colleagues are doing, that other providers are doing to try and make sure that those pathways outside of hospital are as slick and available as they can be, is a key part of avoiding admission where that's the right thing to do. The other part is for those patients who have been admitted, is making sure that they have the onward care. There are challenges in capacity. I don't think that would be a surprise to anyone, and there are differences in terms of the capacity of particularly the more complex packages of care between the Hampshire and the Portsmouth residents, the availability of those. Those are the real difficulties that we are working with partners. I would say that compared to when I started coming to these committees, 7, 8 years ago, the way in which we work together with the different providers, with the councils, is completely different. It is partnership working, but there are still constraints on the amount of resource, and the demand continues to rise. So we see in every population, we see the number of patients, the proportion of patients, in fact, with complex and multiple health needs rising all the time. And it is those patients in particular, the ones with multiple long-term conditions who have the greatest need and often the greatest requirement for support as they're ready to step down and out of hospital. And we haven't seen the growth in the capacity to support those patients in line with the growth in demand.
Thank you. I know you were going to have a follow-up. I think that was your question, but did you have another issue question?
Yeah, my question was what yours was basically. What is the issue? You know, the stopgap. But are there any particular groups? I mean, I'm sure I'm not the only one whose mind is assuming that we're talking about a certain age of patient here, a certain, you know, dynamic. But is there, I mean, do you face issues with when you're treating the homeless people of where to, you know, discharge them to, those kind of things? Are there any themes in particular?
So in addition to the groups of patients I've mentioned, which is those with long-term conditions and particularly those with multiple long-term conditions and frailty, and that is a spectrum of those presentations, you're right, there are a much smaller group, but nonetheless present significant difficulties for the homeless patients. And then, of course, those who have long-standing and complex mental health needs as well. That is a particular subgroup of patients for whom we know nationally, as well as locally, the challenge in supporting them with what they need, which is often not admission to an acute hospital, but sometimes is. But the challenge of supporting them to meet their needs safely is enormous, and it has grown even more significantly than the physical health needs of patients.
Do you have any follow-up on that?
Can I just add to that just
yeah,
slightly?
Of course,
yeah. So I think the homeless has been a real challenge for us over the last 12 months, but there's been a lot of work and energy put into the homeless. Our emergency department were very good at managing the homeless, but we found there's a disconnect between the ones that get admitted. All the information that the emergency department knew about the patients disappeared as they came into the bed base. But we've now got a total team that works with the homeless that get admitted for genuine clinical reasons, with support from the City Council as well. And what we find is now that what was a real challenge in terms of not the number necessary, but how long they were waiting in the hospital to have a discharge destination, the time they're taking is a lot shorter now. And when we're comparing our 240, you are talking on a range of 1 to 10 at any time. Our biggest challenge at the moment is the more complex patients John describes who genuinely need nursing care or care home capacity, which is a real challenged area. And the focus now within the hospital and within the system is that home first. How do we pick them up earlier? How do we make sure that we can wrap around as much as we can to get them home instead of them getting to a point where they need that? There'll be patients that will always need a care home or nursing home. There's probably a cohort in the middle that, if they were picked up earlier, different interventions were made, could probably go home. But the wraparound's not necessarily there. So there's a big piece of work now going on with our colleagues at the ICB and with Hampshire Isle of Wight FT and the councils around how do we pick them up earlier to get them home with a package of care, with some equipment, instead of what inevitably potentially becomes they need a respite element or they generally need a care home, nursing home option.
Any more follow-ups on this? I've got Councillor Raffaello next.
Thank you for that. The other point I was just going to ask about, certainly from our perspective, the handover between the new and old ED was really good. It went really well, and I hope you felt that as well. I had a funny email from one of the constituents who had been taken into the lovely care, but they were it was only one person. They were disappointed it wasn't quite as big and as luxurious as they expected. Now, I'm not really sure what they expected, but it did strike me that when you design these things, you think this is what the need's going to be, and then you realise it's there. Just look at your parking, for example. Now you've got it and it's working. Do you think this is going to last you for how many years? Or?
It's a very fair question. I wouldn't say it was luxurious. No, it is sizable, but it's not in terms of the majors. For the patients who have the greatest acuity of illness, it actually hasn't got a greater capacity than our old department. What it does have is an enlarged resuscitation area, and it has much better ability to manage the patients in in better spaces, better sized spaces, better separation of different clinical areas. But the sizing of, in terms of its actual capacity, was really carefully modelled, not just on hypothetical numbers, but based on benchmarking, based on our own data, and based on some different ways of working that we are already incorporating and are quoted in the report. A big part of that is trying, again, to make sure that patients who have an alternative to coming into the emergency department are able to access that alternative before they get to the emergency department. Some of it is now streaming patients who have effectively a primary care need but present to the emergency department away from the emergency department itself. And those things are, I think, are key to making sure that the patients who end up coming into the department are the ones who really need to be there. And the answer is, bluntly, that should be the right capacity for those patients for some time to come. But we do need, for that to be true, we do need to make sure that all of the elements of the healthcare system are working in the way that they need to provide the right alternatives for those patients for who they exist. Thank you.
Rookie mistake. On page 27, at the top of the page, it's about ambulance handover time. So really useful, interesting statistical evidence there so actually going backwards, there's a big change there in the number of minutes. Are you sort of fairly confident that's to do with the new emergency department, or could those sort of changes be random?
I was going to let Simon, because I think he should take some of the really positive opportunity to respond on that. But I'll start. It is absolutely, in significant part, due to the new emergency department. The new emergency department has enabled ways of working and flow of patients through that department that we just couldn't have got working in the old department. And I know many of you visited and saw what it was like, but it was a mess of infrastructure that had grown up through decades of expansion beyond its designed capacity. This new department, although overall the same in terms of number of clinical spaces, is about 4 times the physical square footage, and as such it is lined up with clinical thinking and clinical design to make sure that the pathways meet the patient need. That said, had we just built that and left everything else across the pathway from ambulance arrival to discharge from hospital exactly the same, I don't think it would have realised the benefits that it has done, and that's been down to the continuous flow approach. And flow sounds like a euphemism, but actually it is genuinely the right way of looking at the whole pathway, which is that patients have to flow through it to meet their care needs. And so an awful lot of work went in the run-up to opening the new department to making sure that the movement of patients out of the emergency department to ideally the right clinical area, but spreading those patients who have a decision to admit and therefore need to come into the hospital as quickly as possible out of the emergency department is a key part to letting the department itself function and offload patients at the front end.
Did you want to speak as well?
Yeah, I think really the ambulance performance is a total trust ownership of that performance, because as John says, if it was just the ambulance service, the emergency department, at some point patients do require admission. So it's very, very much along the imaging specialities as well, owning that pathway. We do know that, and it's not just us, nationally, if you have a congested ED with no space, you end up usually admitting more patients. So it's how you keep that continuous flow going through the emergency department into the specialities and get that patient to the right speciality quicker, then increases their chance of discharging earlier than them being in ED for X amount of time, stuck with nowhere to go. And I think it has been a genuine total trust response across all divisions. So it's not just medicine, there is surgery in there as well as orthopedics, as well as gynecology, etc. So it has been a total trust. I think we've shown since that December position a continued improvement, and we're now in month 3 of that. We're now basically how do you sustain that and how do you prepare for next winter, because every winter is absolutely more challenging than the last, although we don't think they can ever be. They always usually are. But I think it was absolutely a decision-making process pre the move that then played out as part of the move and now is a continuing process from a policy and a flow perspective.
Yeah, sorry for sort of fluffing the question really, but I wanted just to highlight that because obviously it's very positive news. Does anyone have any more questions on this particular issue? Any other questions? So could I formally thank you as well for the putting on the visits and for giving up your time and your colleagues' times. It was really, I found it really interesting and great facilities there. Yeah, it was really, really good. So could we formally thank the Trust for that? Thank you. You're welcome. So we're going to note your report. You're welcome to stay, but equally we realise that if you want to go away, do. Thank you very much. Okay, so next agenda item is agenda item 6, Hampshire and Isle of Wight ICB. So we've got Bernie Allen, Dr. Linda Colley, James Roach and Emily Petter. If you'd like to come forward. Sorry if I've said any names wrong, my name gets mispronounced all the time. So it's the usual thing that we've read your report. You're welcome to give a summary if you want to. I don't know if everyone realises, but there's been sort of a big change announced today. So Bernie, I don't know if you just want to just summarise, but we appreciate. So what I wanted to say is that you obviously don't know all of what's happened because it's happening now. So over to you.
That's very kind of you, Chair. I do appreciate that. So, yes, we've received recent announcements today that the Secretary of State is planning to make some significant changes to our regulatory environment. So for those of you who haven't seen the news today, NHS England, who is our regulator, they had previously announced that there were going to be some quite significant changes in coming transition. Sir Jim Mackey, who was previously chair of NHS Improvement, was taken on that role. We've heard the senior leadership within NHSE were largely moving away from their roles, and what we've heard today is that our Prime Minister intends to disband NHS England. Okay, so that is the context in which we're here today. But the bits I think I can and will talk about are the chairs of NHS Hampshire and Isle of Wight, and in fact all of our provider trusts are already in London today. They were going to be in London today anyway, with the Secretary of State, maybe some different members of NHS England than they perhaps originally anticipated, but they are there with Sir Jim Mackey, never get his name right, sorry, and to understand what that really does mean for expectations. We also know from our regulatory environment the key expectations within the planning guidance about improvement times to all of our pathways, for whatever pathway you're waiting for, is an expectation that is not going to go away. That is what we will continue to focus on as commissioners and providers of care in the city, and also that really strong focus on closing the gap on equity of access and outcomes for all of our populations. That said, we are in the sort of interim stages of our planning cycle. So draft plans have gone in, financial envelopes, expected outcomes. I'd perhaps prefer not to be drawn on any further of that at the moment, and would ask for your patience until, we complete the planning cycle, but B, also know for our colleagues and our regulators what that would mean. What I would like us to talk about and bring to you, though, is, where as NHS Hampshire and Isle of Wight we have already been focusing on, and as you know, we've been and talked to you previously about our renewed ambition, that strategic aim about how we're going to organise ourselves. And that is all based upon that expectation about improving the outcomes that matter to people, the experience of receiving care, for our workforce, the experience of providing care, because we do know that empowered staff, as you've heard from today, from the midwifery units, do make a real change.
and that we do use evidence to deliver the effectiveness or the most effective care that we can for our populations. One of the things that we've launched since we last saw you was our clinical framework. I've put some information about that in the presentation, and we have Dr. Linda Colley here that will talk to that if you have any questions on that. And then the latter part really to say is the 3 or 4 areas that we were already working on collectively as commissioners that we continue to work on is healthy ageing, our frailty, and how we really focus in on supporting those populations is a big part of our work. Cardiovascular health has always been an issue for residents in the city, and if you recall, we've spent the last 12 months really working across a number of different providers working together. And, you know, for example, we've seen our pharmacists doing some of the checks. We've been out to different parts of the city, you know, outside the football, doing some checks. And where we've made those targeted changes, we're seeing the benefits of that. We moved from the bottom of the league in terms of cardiovascular testing and knowledge in our population to now being the top of the league in those areas. So, you know, where we do focus our efforts and work together, we're seeing successes. Our other big areas of focus for this year are the neighbourhood working and our integrated neighbourhood ways of working that we plan to work, and all of the work that we continue to do in our primary care, same-day access and resilience. And James Roach has been here before, and he's here again to talk to us specifically about the primary care performance and access. So I won't say anything more. We'll take the questions that we can answer, Chair.
Apologies to councillors here. I forgot to ask you to introduce yourselves. I know it's because I recognise you, but we've got a new member. So could you introduce your name and your role, please?
Sorry. So
That's my fault.
I'm Bernie Allen. I am the Partnership Director for Portsmouth from NHS Hampshire and Isle of Wight. It's my job to engage with the city and be the voice of the city back into our commissioning conversations.
James Roach, Director of Primary Care and Local Care at the ICB.
And I'm Dr. Linda Colley. I'm a local GP here in Portsmouth. I'm Clinical Director for Portsmouth NHS Hampshire and Isle of Wight, and I'm Co-Chair of the Health and Wellbeing Board.
Thank you. So sorry about that. So over to members. Do you have any questions? I know, Councillor Ashwell, you had a question from earlier. Do you want to go to that one?
It's probably me not reading the table correctly. So on page 8 of the tables you have, so the GP practice is the list. I didn't quite understand the first column and how that relates to the number of patients.
It's page 36 of our pack.
Yeah, 36,
yeah.
sorry.
I mean, the national proxy is we do the number of appointments per 1,000 patients. We can add in the list size if that's helpful and the number of GPs. We did adapt this from the last meeting because I think you made a request to include all of the South East, which we've done. But what we can do, we can add a column on practice size and what we know in terms of number of GPs. So take me on practice, for example. I think there's 40,000 patients there. They've got 22 GPs, so it's useful for you just to see the context. And of course, you'll know some parts of the patch have more GPs per head than others. Portsmouth traditionally has struggled, but I think it's another area in which we've made an improvement and we've recruited more GPs to Portsmouth as well. The only point I would add is that access is more than the GP. So we're starting to see more appointments for nurses, pharmacists and other parts of the primary care team as well. So we'll put the GP proxy in for reference, but we're trying to drive more activity through primary care team.
Did you have a follow-up?
Yeah, a follow-up, yeah. So I'm sorry, I'm just going to go back to the meal and health one. So I've noticed that 374 patients have moved out of the practice. Do you have any reasons, or where have those people gone? Any reasons why they're moving out?
No, and I think, with respect, I think you've slightly misinterpreted the data. So one of the things I will do is make sure there's a bit of a descriptor around which column or each column means. But Linda, do you want to pick up what that means in real terms?
Yeah, so in what we're actually looking at is how many appointments were had. It's not about patients moving out. So actually for me where was it on the list? They did 374 less appointments this January than they did last January. That's what that's saying. As you can see, quite a lot of the practices did more this January than last January.
And as you know, patients are very reluctant to leave their practice, and if anything, we've seen an increase year on year. So
I've got another follow-up then. So do you know the reasons why they've seen less patients?
some of it will be seasonal, some of it will be just the nature of the demand. You don't get a cyclical flow of demand, if you like. Some months will be busier. But again, what we do know year on year is about 7% higher than last year across Hampshire and the Isle of Wight. But that will differ practice to practice. So I don't think there's any real reason other than that's how the numbers have fallen in that period.
Thank you.
I've got a question on this, and then it's Councillor Heaney next, then Councillor Oliver. The year-on-year differences are all over the place, but there's no narrative why they might be, which I guess is sort of the crucial question, really. Do you have any idea why the year-on-year differences are different with the different practices?
Sorry, can I just ask, we're struggling to actually understand what these columns mean, and that might help. Yeah, is that okay? Can you just actually go through what does the first column, what are those numbers?
So, again, national proxy, we measure access on the number of appointments per 1,000 patient, and that's compared. So there'll be different list sizes. You may have one practice with 7,000 patients, one with 40,000 patients. So it's a way of measuring that. January 25 is the total number of GP appointments per practice compared with the previous year. So that's a total, if you like, and that won't all be GP appointments. It will be split by healthcare professional. Actually had. And then obviously year-on-year difference in numerical and percentage terms. I think, Chair, it'd be helpful to do a descriptor of the tables, but also give a bit more narrative in terms of what it means overall.
I mean, yeah, that would be really
yeah,
helpful.
We keep adding to the table, don't we? With every
I know.
So
is there an answer you can give us now about why there is such differences year on year with practices? Is it, what I'm trying to guess is that, well, sorry, what I'm trying to find out, I suppose, once I know that, does anything get done about it? You know, is there any sort of, anything that can be done about it? Is there a cause for concern? That sort of thing.
Not necessarily a cause for concern. There will be fluctuation. So that, you know, if I present that table in 3 months, you'll probably see a different view in terms of practices that had less appointments compared to the year before will end up having twice as many in April, for example. So some of it is basically the numbers presenting. It might be level of illness. It might be how people access. What I will say is a lot of people are using other alternatives now. They're using pharmacy first. They're self-caring. They're using digital options as well. So some of this reflects reality of data, different trends month on month, but actually the fact that some of our patients are using different access routes, which is something we'd want to encourage.
So next I've got Councillor Heaney, then Oliver, then Finian.
On a different area, it's about the strategic shifts you got at the beginning, which I think is interesting. You'll probably know I have banged on quite a lot about how we get this transition from hospital to community and how challenging it is. And I see you've got some really interesting things there, which I think are about neighbourhood health, standardised community health services, etc. I suppose I have two questions. One is, how are you going to measure that change and how effective it is? And can you tell me what a modern GP is?
Yeah, there's the modern GP.
There's a modern GP sitting there.
And Linda can pick that up. In terms of the shift, so there's a couple of ways where we're measuring it. One is fiscal, so how much investment are we making out of hospital compared to previous years? So left shift is about moving resource from one part of the system to the other. That's money, that's staff, that's expertise, that's the point at which we provide care. For each of those areas, we have a view on the level of demand we could manage differently. So it might mean that we can manage more frail elderly people in the community or more people with CVD independently in the community. So we measure in terms of numbers and access. Each of those schemes will have a view in terms of clinical outcomes. So are we improving outcomes? So take CVD. We know we need to screen more people with hypertension. If we screen and we see they're at risk of CVD or stroke, and intervening earlier, are we improving clinical outcomes? So there's a range of different measures. I think it'd be useful to come back here perhaps in 6 months to let you know how those schemes are going and how those outcomes have followed through.
did you want me to come in about the modern GP bit? Yeah, so I think it's really important to note that the GP bit is not the GP as in the doctor, it is the primary care team, and so modern general practice is that wider team, how we utilise that wider team and what resources and how we link in with our community teams better and different. That's what makes it modern general practice rather than the doctor bit.
And sometimes a modern GP may not be a person. It might be a digital route to access as well.
Councillor Heaney, do you have any follow-ups on this issue?
That's okay. I'll obviously await the progress on this because it looks interesting, so thank you for that.
Councillor Oliver, you've done yours, and Councillor Meehan?
Thank you, Chair. Just a couple of things. The health checkups, the free prevention ones over 40s in Portsmouth. Can I ask what the uptake is? And from that, any sort of information or data around prevention, you know, like cholesterol, blood pressure, etc., any help that came out that way? And also if you target certain demographics for the hard-to-reach communities. Sorry, it's a lot there. It's probably in your report.
So I'll probably come back on the specifics.
Yeah.
We do offer screening. All jokes aside, I had mine on Monday. So we come back on take-up and learning as to hard-to-reach groups where we've made impact. What we do know, and that the dedicated CVD screening programme that I talked about in terms of where we've had real success, that has actively gone in through our pharmacists, through being at different venues to engage with people differently, which has then led to people having the test, which has then led to people taking preventative action. Does that mean we will see an immediate impact in flow-through? No, because some of this stuff is generational, but they are the examples of where we are taking that proactive action. And as I say, cardiovascular health continues to be one of our priorities this year, because we know that that is an area where we do take collective action. We can make some of the biggest difference and provide that more aligned care.
So in my practice, for an example, we do invite anyone age 40 who meet the criteria. They go with an appointment with the healthcare assistant who does blood pressure, height, weight, make sure they have their panels of bloods, and they run what they call a Q risk, which looks at their cardiovascular risk. And anyone over 10% gets booked a phone call with either the doctor or a pharmacist to discuss starting a statin and lifestyle changes and things. So people do take it up, and it does help pick up blood pressure problems, particularly new diagnosis of diabetes or impaired glucose, ready pre-diabetes that we can act on, and cholesterol very much.
Okay, that's lovely, thank you. And one more question, if I may, Chair. How many missed appointments for GPs or healthcare professionals? And I think we discussed this, James, at Hampshire, didn't we? And what action have you got to determine or to ensure that patients make their appointments, i.e. text messages, etc.?
Yes, there's about 500,000 across Hampshire and the Isle of Wight, and I think I gave a precise figure for Hampshire, didn't I, at the last meeting? So I will provide one for Portsmouth. It's a difficult one, isn't it, in terms of messaging to patients around whether they should or should not attend for their appointment. But clearly, what we're focusing on is actually that's capacity that could have been used in a different way for other people. So there will also be good reasons why people don't turn up, and we discussed that at the HASC, didn't we? It may be their needs are dealt with, they've had a follow-up in another way. It may be it's not easy for the patient to cancel the appointment. And I've heard stories of how difficult it can be for people to sort of make the call and make that point as well. So we need to look at how we can make it easier. But I do think collectively we need to keep reinforcing the message that healthcare appointments are very, very important. It's scarce resource. We need to use it properly. What we are doing across Hampshire and the Isle of Wight is we've launched It Takes a Team, which is our patient engagement programme, which started in Portsmouth. And that's encouraging people to use GP practices a different way, access different points, and do that responsibly as well. But I might just refer to Linda in terms of how they deal with DNAs at her practice.
Do you mind quickly just saying what HASS is? I think I know.
Oh, Hampshire Health Assurance and Scrutiny Committee of Hampshire Council. I'm a regular there as well.
Is that the equivalent of us?
Yeah.
We're
yeah. And
yeah, I thought so.
Councillor Minahan, you're deputy chair, aren't you? Yeah.
Okay, thank you. So did you have a... yeah,
So we do text message reminding. There are certain cohort of patients that might need some extra support, so they may get an extra special text on the day, you know, if they've got some learning difficulties and things and need support. And very much we advertising the surgery more of a this many people attended their appointment rather than missed, because actually if you start advertising about missed appointments, people feel it's okay to miss appointments. So it's just a different way of doing it, and we work, you know, every month we keep the data. We work with our PPG, so our patient participation groups, to look at how we can reduce those numbers as well. It is really difficult.
Did you have any more follow-ups at all on this? No. Okay. Councillor Raffaelli, I think you wanted to speak.
I do, please, thank you. Truth, really, the three strategic shifts, you know, focusing on community, prevention and improved digitisation, etc., they're not new.
No.
What's different? Is there anything different now that's actually going to... Before I heard about the abolition of NHS England, prior to that, did you really think there were real differences coming along, or is it just more of the same pathway?
I think the big difference is we've done it in small parts, in small ways, in different parts of the system. I think the difference now is that the system collectively has identified what we're doing in each of those three areas. We're signing up to single schemes and programmes, and we're making real investment. So hopefully that's the difference. We're putting a bit of meat on the bones, if you like, in terms of money, focus, priority and working together. I think the key shift is us doing it as one health and care system. But you're right, this isn't new. Portsmouth have done integrated neighbourhood working for a long time. We've done a lot of digital investment into primary care. And, you know, so Eugene will talk about Hampshire and Isle of Wight Community Trust. There's a lot happening led by them, which is actually supporting people away from hospital in the community. What we're doing is accelerating it, joining it up and putting some money behind it.
So would it be fair to say that there's confidence within the people who are actually delivering at this time things will move, is that?
Yeah, starting to. So take integrated neighbourhood work in. We put a business case through internally 2 weeks ago. That was signed off, and we're starting to make investment in priority neighbourhoods, and Portsmouth will be one of those.
An absolutely minor one. Obviously, the broader church of deliverers in primary care is only a good thing. There's been a lot of bad press recently, however, on physicians' assistants. I don't know how much of that's penetrated into your business delivery model, but do you have anything to say about that?
I'll let Linda respond in terms of the national view, but I don't think we've got a huge number of physicians' associates anyway in Hampshire, the Isle of Wight, so I think it's less of an issue here than other areas.
So I think nationally, physician associates have their place, but it has to be very well supervised and supported. And so I think the feeling nationally is that they may be better placed in secondary care rather than primary care. My PCN was one of the only ones that did have physician associates. We had 6. To be fair, they were very well skilled and with the right support provided excellent service. Unfortunately, financially, we don't have them anymore. But you know, it wasn't because their skills weren't there. I think they do have a place. It just has to be well supported and well thought out about what that place is.
Okay. Councillor Oliver?
I was just going on, so you had 6 and they've gone now. How much appointments, how much pressure has that added onto the GPs? Like, so they were obviously taking appointments that for patients that would have otherwise been seeing a GP.
Yes.
And in my experience, were looked after very, very well.
Mm.
Now, we've got to wait that extra bit longer because the GPs are already under pressure. So you've essentially lost a team of six people in your workplace.
Across the PCN, yes.
Across the PCN. So that's obviously going to have some kind of impact and fallout on patients being able to see face-to-face contact.
So mitigated by the fact that at the same time we've had a recruitment increase in GPs.
I've got a question which probably won't make any sense. So, as an organisation, you collect the data for the different GP practices. Is there anything that you do or can do to improve GP practices? So I think that's basically what we're always trying to get down to.
Yeah, you go first and I'll come in globally.
So some of the things we do offer is things like the GP improvement programme, which people go in and help support the practices to improve their systems. Certainly my practice is benefiting from that at the moment, and you look at you compare yourself with they come in with other people, what they've done, and you can really look and focus on what is your needs for your patients, how we can change your systems to be more effective. So one of the things we're doing in my practice, for example, is introducing a new care navigation tool so that patients are seeing the right clinician the first time and not wasting appointments. So clearly something that needs face-to-face doesn't get booked in for a phone call where you then have to go, lovely, but I need to see you. So it's small things like that, but there definitely is support packages in place to help with primary care.
Councillor Oliver.
Sorry, and just to add,
sorry,
I think I've raised it here before. With the other thing we're doing is we're investing more in general practice resilience. So we recognise, and you would have seen 2 weeks ago, new contract offer. So nationally, that was 889 million more pounds. That's about 25 to 30 million extra for GPs across Hampshire and the Isle of Wight. But when you start to take into consideration the NI increase, running costs, national living wage, estates issues, for some GPs, that might only be a 3 or 4% increase on last year. So we've used that as a platform to go further. So we're investing in resilience in primary care. So looking at where we can invest in estate, where we can invest in transformation, where we can support those practices that are financially challenged. So it's a continual cycle of supporting the business of general practice. And it's part of that shift left as well. A lot of that innovation will be close to general practice. So we need to make sure the money follows.
Councillor Oliver.
No, go on.
I was just going to say, I think it's really important to note that we've come a long way in Portsmouth in terms of number of GPs. You know, last year I couldn't get a GP to come and work for my practice, come what may. No matter what we offered, we just couldn't get them. And now we're fully recruited. So the environment that we're working in is clearly more attractive to the new GPs coming in. And that's partly because we're doing things differently.
Yeah. That's cool.
Great, thank you.
Can I ask a question from a service user? I think GPs are fantastic when you get past your reception team. So I just wondered if actually some of the difficulties and the negativity that GPs' practices receive is actually because of that first point of contact is faced with a receptionist who obviously has whatever their protocol is about how we try and get an appointment. Are they employed by the practice? What training do they receive? Because I think if, you know, I look at myself, but also I respond on behalf of my constituents, that is a massive, massive issue. It's like, you know, you could have your arm hanging off and, you know, it's obviously you should go to A&E, but they're busy. But it's that frustration that actually we get talking to our constituents is just getting past that phone call.
Yeah. And I think they are employed directly by each individual practice, and so what they are trained to do will be different depending on each individual practice and their own systems. I think one of the things, and certainly in the new contract it does talk about, is that trying to risk stratify patients so that the right people are getting into the appointments that are needed. I think a consistency of approach. So if you walk in the door, if you pick up a phone or you go online, it's the same response. You're not getting different stories depending on which level, which access. And obviously there is a lot more awareness for people with difficulties like learning difficulties, autism, etc., to make sure they're getting fair access as well. So I think there's a lot of available support. So things that I mentioned, like the care navigation tools, they're designed by clinicians. It's very simple. Somebody phones up with an earache, click on earache, it tells you exactly which pathway you need to follow. That may be pharmacy, but if it's this, GP, face-to-face. So there's lots of tools out there to help support the care navigators who have a really difficult job, because at the end of the day, there are only so many appointments in any one day, and they're often seen as, you know, as a barrier. But actually, often it's the communication, it's the way they're speaking to people on the phone and things, and so a lot of work about how you do basic customer service, basically, is often what's missing, rather than actual knowledge from the reception.
Personally, don't want my receptionist to diagnose me. So I'm more than happy for them to communicate that I need to see a GP because that's what I want. But yeah, no, I appreciate that. Thank you very much.
Is there a standard sort of package, if you like, for all GP practices of best practice of the customer route? And that could be online as well, so it's not just on the phone.
I mean, the main thing, and again, this came up at HASC, so it's a similar theme, isn't it, in terms of people's experience. So as part of the Primary Care Access Recovery Plan, we did a lot of work with our GP receptionists. We've invested in care navigation, we've invested in social prescribing. So actually, that's about, A, making it easier for people to get through, first of all, and then make sure they're triaged to the right person to make the right decision about their care moving forward. So we have invested in training of receptionists so they can become call handlers, social prescribers and care navigators. So you hopefully see that improvement over time. I think the other thing is, as Linda said, often GPs themselves are involved in that triage at the front of the practice, if you like. So that ensures that people are getting the right outcome. And as challenging as it is for people, that's the aim. The aim is to ensure that the right people get seen on the day, and if not, they're navigated to other parts of the system.
Thank you. Next I've got Councillor Heaney.
It's an observation on the discussion, really, that Councillor Oliver raised, because sometimes when you're trying to get a GP, you don't necessarily know that you've got a problem, but you don't know what it is, so you're uncertain. You don't know whether you need to do something about it or not. And as you get older, maybe sometimes you do think, actually, is this something I need to worry about, or is it not? So what you sometimes get is you go to the GP, you speak to the receptionist, and obviously they're keen to try and make sure that they make the best use of appointments. And if you're a bit vague about what the problem is, they may well say, well, you don't, go and see someone else. Or, they'll tell you to use the e-consult, which is fine. But as I discovered when trying to use it, it's always a bit challenging to get on it because it doesn't open up until 8 o'clock, and then it closes off, and then it finishes before the end of the day. So you can spend some time trying to get onto that. So what you do is you try another route. So you ring 101 and you speak to somebody there and tell them what your sins are. And they say, yeah, we think that might be something. I'll do a note to your GP to get them to contact you. So you find another route by which you get what you actually wanted. And it can almost seem like a bit of a game. You try to sort of, which route shall I choose? How do I get my appointment done? How do I get somebody to tell me something about this problem? I did get a call back from the GP, and in the end, it wasn't what I thought it was. They thought it was something else, and they said, it's okay at the moment, but if it gets worse, come back to us. So I'm much more reassured now. But it's taken about nearly a month to get there, and that's the sort of thing about how the route works and how we can try and improve that. Because for patients, it can seem like it's an obstacle course you have to go through.
Yeah, and as part of, so when you phone the practice now, if they are going total triage, there are some people who can't use online, but most practices who've gone total triage or are heading that way have some sort of system where the receptionist can fill in some information on the form and present it to the GP for a quick triage. So at least the GP gets a quick idea and then can do exactly what you've done, but not a month, hopefully. Hopefully it would be done in a much more timely manner.
Can you explain why the e-consult isn't live all the time? Is it because there's literally someone there at the other end? Because I think especially for elderly people who do use online services, it's a really odd thing because you get encouraged to use it and then you log on, you eventually find it somewhere on the GP surgery's website hidden away, and then it says it's closed, and
so
that doesn't really make
solution
much sense
is en route. So one of the issues one of the changes in the new contract was an expectation that those virtual routes of access are on all day, so from 8 till 6. So I think from October that will start to sort of ramp up. What we need to do is look at it in the context of that development. We probably need to develop our own strategy in terms of how people can access that seamlessly and make sure it works the other end. So that will improve over time in line with the new contract.
So that sounds good. But again, with online services, you expect to be able to use it 24 hours a day. So I think people would still. So it's obviously better than only being on for an hour or 2 hours or whatever it might be. But actually, someone would then look at perhaps go online in the evening or something, thinking they're doing helping the NHS and GP surgeries, not ringing up, all that sort of thing, and still find that the e-consult is closed. Is it because there's literally someone at the other end?
Yeah.
Okay, but they couldn't be sort of like an inbox that.
I mean, over time there may be an AI element to some of this where it's not dependent on clinical input, but for it to be safe and for people to be streamed the right way, you still need GP or clinician availability. And as much as they'd like to, they don't currently work 24 hours a day.
For the e-consult specifically, there's no way of it determining if it's an acute or a routine issue, and so it all comes through, and the clinician on the other side has to open them, read them all, and decide is it urgent or not. There are meant to be safety mechanisms built in, but sometimes patients know that if they answer that question, it won't fill, so they change the answer, actually removing the safety element sometimes. So as a practice, we like to respond within 24 hours. working hours, that is, so we have to cap it in some way, otherwise you physically can't keep it safe. As we move towards October, that as a practice now, we'll have to look at how we make those changes, or whether the system can be a bit more nuanced to say urgent closes at this time, but non-urgent can stay for longer, because you have to be able to distinguish the two so that you can deal with the safety element first, and then the non-urgent things can wait for a couple more days. So I think that's the work we're going to have to do now between now and the go live in October.
That does make sense to me, so thanks for that. I guess the other thing is that obviously people can email as well, can't they? You're not going to email in if it's especially if it's saying don't email in if it's an urgent case. But actually just sending the email in an evening, knowing that you've done that, is something that people could do. And I think people get probably confused a bit by e-consults and emails.
Yes, so we don't encourage emails from patients at all, because, as I say, they'll think they're getting help now because they've emailed in. It could go to an inbox that's not manned very often, or manned by somebody who's on annual leave. So we only encourage phone call or e-consult. And it clearly states, if e-consult is closed, you pick up the phone and you phone the surgery, and would hope to get... And every surgery has a level of same-day access that usually is capped because of capacity, but they shouldn't be phoned back tomorrow. It should be, this is what you can do right now if you need it. That's what the answer they should be getting.
Thank you. Any more questions, members? No?
Yeah, go on.
Oh, go on,
I
Councillor
just
Oliver.
wondered if you've, in your practices, there's any kind of system, if the same people are phoning back and not able to get an appointment, do you have like a flag system that says, oh, Mr. Smith has actually phoned consecutively for the last 3 days and still hasn't physically seen a GP? Because that is where, in my opinion, patients, we start to jump through hoops. Talking from my experience, my father was unwell. It was during the COVID time. He couldn't get into a GP. For about 6 to 8 weeks, he was unable to see a GP. So I was like, stuff it, we're going to phone 11, get to the out of hours. Somebody literally, with 4 fingers, pressed his tummy and said, oh, that's not supposed to be there. And he was diagnosed with stage 4 bowel cancer. Now, in my experience, that was a preventable disease before. So I just wondered if is there a flagging system that actually goes, you know what, like this, we can see on the system that this patient has rung about the same issue and we actually haven't seen them. I just wondered.
So I suppose only if they've managed to get as far as speaking to someone. So if they've spoken to a receptionist, the receptionists are supposed to document in the notes, you know, advised to go to pharmacy first, or it's... Yeah, but if it's not documented that they've tried, there's no way, unless somebody complains, and then we can search their mobile number or their home number and we can see how many calls, and we can listen to the calls. So if they've been told advice, if patients have come in and said, I wasn't happy with the advice, or the receptionist was rude, we can listen to those calls. And if the receptionist was rude, we can go and address it with the said receptionist. If they've spoken to a GP and had telephone consultation after telephone consultation and not been seen, yes, then absolutely there'll be records of all of that. But it doesn't flag unless the next GP comes along and you say, oh, hold on, you've spoken to 3 million people. Have you actually been examined? Yes or no? And then you bring them in. But, yeah, there's no other way.
Councillor Meenan?
Sorry, I'm just thinking on my feet now. But with the cloud, so you don't wait in a queue, you request a callback, then hopefully that might reduce that occurring in the future.
So it would, if they...
Because you'll know they've called.
But it won't flag.
No.
It wouldn't automatically flag if they called again to say, oh, they called yesterday. The cloud doesn't do that.
Yeah.
So, yes, so patients can, instead of hanging on the phone and being cut off, unfortunately, like Councillor Gerardo was, you can have asked for a call back and it will call them back that day. But it wouldn't, if they phoned tomorrow, say, oh, that person was expecting a call back yesterday. It's not that clever.
But possibly with AI, you could...
Well, potentially with AI.
That could work that way. You could identify a pattern.
And I think if you do some of the digital online tools, they probably do have a level of that, which may be helpful.
Like those with mental health as well, it can be quite a challenge to kind of pick up the phone and kind of say, oh, no, I'm really struggling. And I know there's lots of different services out there that are specific for those that are struggling with, you know, intrusive thoughts and that. But actually, if the only number they can think of is their GP, and then it's not flagged, or you know, or it's not noted, those it's just outside the box thing.
Yeah, so obviously there's the mental health hub. There's a lot of publicity about that at the moment, and we are, one of the surgeries straight in is going to be doing a trial where when you go through on the phone, there's an option for mental health. that you can press, and it will direct you directly to the hub. So you don't have to speak to a receptionist or wait for the doctor. It will take you directly to the hub. I say that is a trial. If it works, they'll try and roll it out across the city.
Thank you. Any more questions from members? So thank you very much. We note your report. Thanks for coming today, and good luck with all the upcoming changes. You are welcome to stay for the last item, but we totally understand if you need to go. Okay, so the next item is agenda item 7. Sorry for the wait, Eugene. It's Hampshire and Isle of Wight healthcare update, and I will introduce you. You're Eugene Jones, and it says here Chief Operating Officer. So we've read your report. If you want to give a brief summary, you're welcome to, but if not, we'll ask questions.
Okay, yeah, thank you. I'll just canter through very quickly the highlights. Thanks very much for inviting me this afternoon. This is an update from my previous update where we're sort of approaching the first 6 months now of the new trust being formed. Trust being formed from the 1st of October 2024. As I discussed last time, I think there was we were going through some changes in terms of divisional appointments and a consultation to form the new organisation. I'm really pleased that we've done that. It's happened really successfully. We haven't had any ripple effect in terms of quality or patient outcomes or anything untoward as a result. So we've really worked collaboratively on that. I'm really proud of the work that the teams have done together because it was quite a big undertaking to do that. We're now focusing on our strategy going forward, and that should be launched in April 2025, notwithstanding the conversations that we've had earlier on around sort of organisational form and change nationally. Again, really fantastic engagement from a whole range of stakeholders, people that use our services, the local population, our staff, and other stakeholders. So great that we're moving forward on that. And the quadruple aim is where we're sort of targeting that work. So that's around the strategy will be formed around improving population health outcomes, delivering better care, improving staff experience, and delivering value for money. So they're the sort of key tenets, if you like, of the strategy, which we're hoping to launch in April 2025. Just around our clinical operating model, we are developing communities of practice, which is in the pack. Happy to answer any specific questions around that. But in essence, we'll be taking a life course approach to the way that we deliver care, so from birth all the way through to death, and then looking at those particular sort of population cohorts, if you like, so children and young people, working age, and then people that are older persons, with a tranche of work going through each of those, which is essentially around delivering best practice, bringing in the nice guidance, what nationally is going on, what our contemporaries are providing up and down the country, so that we can be providing the very best. It will challenge and support the clinical services, and it will make sure that we're keeping on top of what we're doing, and it is contemporary and the best that we can offer within that. There's some Portsmouth specific mentions in here too, and I should say that we have a new chair that's in post from the 1st of April. Lynn Hunt, our outgoing chair, finishes this month, and Neil Hayward, our new chair, and Lynn have been working together, and he's been engaging and going out to meet our services in the run-up to him taking formally office on the 1st of April. I'll probably stop there and then happy to answer any specific questions that you might have.
Thank you very much for that. Members, do you have any questions at all? Councillor Raffaelli.
Hello. Thank you for the report. It's by design very high level indeed. And what it doesn't really give me is any feel for what it's like on the ground with this new organisation, 6 months, well, not quite 6 months, four or 5 months. Where do you see your actually delivery challenges are? Where are you putting your time and effort to actually deal with those shortages and the rest?
Yeah, we've got constraints, there is no doubt, but we've also got opportunity. I mean, we heard from our colleagues in the ICB, we're working hand in glove, so this is very much a system working. Simon Parson and John from Portsmouth Hospitals, so we're working together as a system in a way that I don't think we have previously. So in terms of the response to our demand, a lot of that is actually around focusing on the critical mass that we've got, the workforce that we've got in the areas that they can do the best, where they can achieve the best effect, where we can make the biggest outcomes. So some of the work will be around, nationally we've got a mandate to address waiting lists, so people that are waiting too long for their intervention, their care, their treatment, and that's across the board. So we've got a specific action plan now in the Trust where we've conducted a deep dive of all of the care portfolios that are currently waiting, looking at the reasons and the rationale. Some of that's to do with workforce, some of that's to do with care pathways, some of that's to do with the models that we put in place, and we've got an improvement programme going forward to address that. So as we go forward, we can assure ourselves and be confident that the wait times for individuals are going down, which means that they're getting their treatment and their intervention earlier than they're currently doing. That's one thing, and that's an occurrence certainly within Portsmouth and the city around wait times. We've got wait times in a number of key areas that are just far too long that we need to address. We're working with the ICB around the left shift, so part of that is moving from hospital-based care that John and Simon are providing in Portsmouth Hospital into more community-orientated care. So that would be us in terms of our community health services. So again, we're looking at how we can support people who, so people with frailty in the community to avoid their admission into hospital. So again, something that's happening right now is that we have a single point of access that we work with the ambulance crews and our clinicians to avoid people actually being conveyed to hospital via 999 calls where they don't need to be. So we can provide an urgent community response from our community teams to support those individuals. And I've got the stats that shows that across the board, we're diverting quite a high numbers of people away from the acute hospital that would have ordinarily been taken there by ambulance, because our clinicians have said, no, hang on a minute, we can actually treat this person in the community. It's a higher level, it's a greater level of acuity, but we can do that because we've got the technology, we've got the skills, we've got the confidence. So these are the things that we're working together as a system on to address what is fundamentally a demand and capacity problem that we've been facing for years, really. I don't know if that helps.
A little, but I think what I'd be interested in seeing is just exactly, and sorry, I'm jumping here. It's not just Portsmouth, of course. We're interested in a wider area. Gosport is my particular area of interest. But I would be interested in some of the data you have on the actual access challenges or delivery service capacity areas, where they are, what work you're doing to address it, and your KPIs as you go along to actually demonstrate improvement. I mean, the diverting people who are potentially going to go to hospital unnecessarily is, of course, great stuff. But as we heard earlier, it's something that people have been trying to do for a long time, and there's been various initiatives, some of which have continued through, some of which have fallen by the wayside for different reasons. So without actually seeing where it is, your top half dozen challenges, how you're addressing them, I think would be the kind of stuff I'd be really interested in hearing from you next time. If that's okay, Chair, that's the kind of thing, yeah.
Yeah, happy to do that. And obviously we provide some of the primary care services within Gosport, within the Trust. And again, the aim here is to try and make sure that we've got care that's proportionately delivered at the point of access for the individual. So primary care, where we can deliver primary care in greater numbers, in greater volumes for people to get the care, treatment, diagnosis that they need at the earliest stage, that's great. Where you need something which is more a greater level of specialism, if you like, than primary care, that needs to be accessible in the same way. And so I can happy to provide, I guess, our journey around how we want to make the interface between primary care, secondary and specialist services, and also the journey back out into self-care and people actually managing their own conditions. We're happy to do that. The other area that we really want to focus on, which I think is not new, but it's got a new emphasis around it, which is prevention. So we recognise that that people develop long-term conditions over the long term. Some of that is around lifestyle, some of that is around choices. It's a public health message, really, that we feel that we're obligated to provide and support people, because otherwise we're going to be treating, we're going to be getting better at treating long-term conditions, and that's not really what we want to be doing. We want to be preventing people developing long-term conditions in the first place. So very much thrust in terms of turning the axis on its head and looking more about prevention and disease management rather than what we have been doing over the years, which is around treatment and responding to that.
Did you have a follow-up on this?
I do. I don't want to hog.
No, it's fine.
But, I mean, I think you guys own the Willow Group, for example, and both as a family patient and with lots of constituents, I remember there has been a marked change in the delivery from that group for the better over the last 6 months, and I'd love to see how you got there. But the kind of challenges that are still enjoyed are your access to IAPT or to CAMS or to things like that. They're really an issue for everybody, and I'm not quite sure the focus on that. And I've just got one hobby horse I would just mention, if I may. Prevention is absolutely the way ahead. But if anybody tries to convince me that prevention will remove all multiple case and pathology systems, and it won't. It'll just mean more people will live longer, and there'll be inevitable breakdowns. So whilst you reduce some of the really big things, you ain't going to get rid of the need for long-term multiple pathology care and treatment. So yes, it'll help the shift, but it ain't going to take it away.
I agree, but I think we've got a sort of we've got a moral obligation to allow people to enjoy their lives and well-being as much as we can. So we can't eradicate illness, and we can't, although we can in some cases, and we've made significant strides in terms of medicine over the years. But what we do need to make sure is that where people have got long-term conditions, that they're not able to fulfil their lives and enriched in the way that they want to be, we've got an opportunity to turn that around for those individuals. And I think we're morally obligated to do that. In terms of the Willow Group, just very briefly, the way that has been turned around, and it's great that you've recognised that, I'm really pleased to hear it, is that we had that group and the GP practices that have fallen into the hands, if you like, of providers like ourselves, secondary providers, have been around the failing practices, so practices that haven't been able to sustain. And the Willow Group was staffed significantly by locum doctors. When we inherited the Willow Group, there were very few doctors at all. And so we've had to create an infrastructure within the Willow Group around, safe management and support for that practice and the list of people that they serve, and bring in additional temporary locum doctors. What I can say now is that I think part of the reason, and we recognise this in temporary staffing across the board, is that we've got substantive doctors now in the Willow Group, not locums. We've got people who are invested, that work for the organisation, that are working for the local community, that want to leave a stamp, that want to do good in terms of that community, rather than locum doctors. And we're doing that in other practices across Hampshire too, because we recognise the importance of that having a stake in that local community is so important.
Thank you. Councillor Harris?
Yes, I was reading about the Portsmouth Mental Health Hub. So a couple of questions is, one, is that only available to people in Portsmouth, and would it be extended to, I'm from Havant, wonder whether our residents, and also I was kind of interested in the capacity of that service, because you've got 300 live web chats, which sounds, that sounds an awful lot. What's the capacity of that service? Thoughts on that? Thank you.
Yeah, so it's started as a sort of pilot, if you like, and we're currently reviewing the ability to scale that to a wider community across the organisation potentially, because in terms of the initial pilot, the proof of concept has been proven that there's a real ability for people to actually receive advice in a friendly, non-demeaning manner from people who want to be helpful and signpost you to the right services. Now we know that especially within mental health, it's often the case that people come to the mental health services inappropriately. They need support, but they don't need secondary mental health support. They might need support in primary care. They might need support in terms of their, challenges that they've got in terms of life or in work or in families. That isn't all of the business of the specialist mental health provider. So the hub is very good at looking at those specific characteristics, the needs of the individual, and then making sure that they get to that place. We haven't got that replicated across the whole organisation currently, but other trusts have done. So, for example, in Berkshire Healthcare, where I worked some time ago, they had a hub that was for the whole of Berkshire, that they would receive all referrals into that hub. It was supported by administration and clinical staff, and then they would make a judgment about, with the individual or the referrer, where that individual's needs would be best met. It reduces waste, it reduces duplication, people get to the right place quicker and more readily than the system that we have at the moment, which is sometimes people go round and round and round in, and it avoids that. So it's something that we are looking at and looking at potentially scaling up. So it may well be available for you in the future.
Did you have a follow-up? Okay. Any more questions on this issue, or any more questions at all? So thank you very much for coming today, Eugene. We'll note your report. And thank you, members. That's all on the agenda today. The next meeting is on Wednesday, the 11th of June. So I officially close the meeting and ask Lisa to stop the live stream. Thank you.